So if you think about what you heard, that you're similar, you have a similar viewpoint as Dr. O'Sullivan. Contrast that with anything that you heard for this group that has not been resolved with your standard care and has not resolved with good sound physiotherapy. How do you differ from his thoughts on that group of patients?
I think the big difference is that I have far more confidence in my ability to make a pathoanatomic diagnosis than he does.
Okay.
I don't think there's any. He seems very dependent on the MRI for making those decisions. So whereas I personally have tested my diagnostic accuracy against valid reference standards, and I feel confident that I can make a diagnosis. So, for example, if a person satisfies my criteria for non-mechanical discogenic pain, mechanical discogenic pain I'll usually get better with just some McKenzie stuff, but that's not a problem. But the non-mechanical discogenic pain, for facetogenic pain, for sacroiliac joint pain, for nerve root pain, that is not surgical, then I work very closely with musculoskeletal physicians and surgeons to do diagnostic workup for facet and SIJ, and with high-tech imaging for people with anterior column pain. It can be the disc, or it can be the vertebral body. Motor changes. Peter mentioned the fact that he's impressed by motor changes. Not impressed by them, but he regards them as a potential source of pain, which I do also. Mm-hmm. And that was a marker of a painful pathology. That's probably a better way to put it. The motor changes are not the cause of the pain. Mm-hmm. All right, they are a marker for a pathology that produces nociception, which is interpreted as pain. That's the proper way to say it. Yeah. So I work very closely with surgeons, with musculoskeletal physicians who do a good job on doing diagnostic blocks, which I don't do. And then I will, if the person has, for example, a facet or SIJ problem confirmed, for example, then the patient will come back to me after they've had those things confirmed. We'll discuss whether the person goes on to have interventional radiology techniques like steroid injections or radiofrequency denervation, neurotomies, or whether they just learn to live with it. And if they need help with that, we get them to see Tracy, who does all the cognitive behavioral therapy stuff and, acceptance therapies and stuff like that, which are all entirely valid when a person has to live with pain. Sometimes we don't have a solution and they have to learn to live with it and not allow it to control their lives. Well, that's what these people who are experts in doing that, I'm not, but she is, and there are other people in town who are also as good, but I prefer her. She's absolutely superb. And so she works with them and these patients, but she works with me as the, if you like, the mechanic, and she is the as the software manager.
Sure.
That's how I see it.
Yeah, right. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.